Our first presentation is going to be by Dr. Paloma Ochoa, third-year resident. Does hemodialysis decrease the risk of venous thromboemboli?
Thank you, Dr. Freed. Okay, so these are the objectives I'm going to be discussing today. I'm going to talk a little bit about CKD, the role for hemodialysis, heparin in hemodialysis, risk of VTEs in CKD patients, ESRD, other modalities of dialysis, and then comparing heparin in dialysis and systemic heparin levels. So the hypothesis behind this Mythbusters was that patients who undergo hemodialysis are at a decreased risk of VTEs. This includes PE and DVTs. And the idea is that since these patients have their blood filtered and they have certain membranes like surface treated or biocompatible membranes, this decreases the risk of platelet aggregation, decreases the risk of developing clots and then having systemic clots overall. And then also the belief that because the blood is filtered, that's also removing clots as well. Another theory behind this was that heparin in the circuit offers systemic anticoagulation as a heparin is in there. So the patients are exposed to heparin during these dialysis, and so they are protected from VTEs. Another thing was platelet dysfunction, so uremia in patients with CKD, ESRD. This causes a abnormality in platelet aggregation, and then this reduces clot formation. About hemodialysis, at least in the United States, it was first coined successfully by Mr. Gordon Murray, which is a Canadian surgeon. And he was at the University of Toronto, and he worked a lot with heparin and vascular surgeries. And so he thought of the idea of including heparin when anticoagulating patients and trying to filter their blood, basically. And so this is a dialysis circuit. As you can see here, you have usually a double bore access. It can be in a fistula or it can be in a catheter. The blood is retrieved. Heparin enters here prior to the dialyzer, where you have membranes inside, and here is exposed to the dialysate fluid in the opposite direction, removes the waste, and then this is returned to the body. Here you're removing waste products, excess electrolytes, as we know. And so where does heparin play a role in this? So heparin prevents the clot formation in the dialysis filter as well as extracorporeal tubing. Heparin is mostly used in standard hemodialysis just because it is low cost, it is well studied. And just of note, today I'm going to be talking about long-term maintenance dialysis, not CRT, which can sometimes use citrate, or peritoneal dialysis only on one occasion. And so when it comes to chronic kidney disease, according to the KDIGO guidelines, CKD are abnormalities in kidney function over 3 months. This includes hematuria, proteinuria, an albumin-creatinine ratio greater than 30, but especially a glomerular filtration rate less than 60. And as you can see, the CKD stages down here. As the GFR decreases, the CKD stage increases. So here we are at 3, 4, 5. So when it comes to chronic kidney disease and venous thromboemboli, including PE and DVTs, we know that CKD induces a prothrombotic state. This happens from several mechanisms. One is the accumulation of metabolic waste products, like for example, when tryptophan is metabolized, there's tissue factor expression that can stimulate the coagulation cascade. Electrolyte imbalances, potassium and calcium has been shown to cause endothelial dysfunction. And then overall, the decline in renal function is an inflammatory state, which has been linked to the development of VTEs. And this is, again, through endothelial function alterations and alteration in levels of fibrinogen, which can lead to fibrin and then cause clot formation. And so how at risk are these patients with chronic kidney disease for development of VTEs? And surprisingly, a lot of these studies are more recent than we would think, because looking back at studies from like 2000, they were actually case reports. So they believe they was extremely rare. So there was this meta-analysis done in China that included 14 studies with 1.6 million participants from USA, Denmark, Netherlands. And inclusion criteria were patients greater than 18 years old with CKD or ESRD on hemodialysis or PD, and this excluded transplant patients. And so what they found was that as the CKD stage increased, the odds of an event occurring of a VTE was higher. So as you can see here in stage 2, it was 1.5, to stage 3, 2.28, and then CKD stage 3, 4, not as high as CKD stage 3, but still higher than CKD stage 2. So in other words, there was another study that put it this way. So for every 10 milliliters of GFR that decreased, you had a VT risk increase by 1.13 fold. And so what about with patients with ESRD? What is their risk of VTEs? And this study went further to look at these patients as well. And they had an odds ratio of 3.68, which was even higher than patients with CKD alone, which was surprising because you're technically supposed to be removing these metabolic waste products that increase clotting and electrolyte imbalances. So what is it about dialysis that increases VTEs? So going down to also the mechanism of action. So one of the things they considered was air bubbles during dialysis and the catheter. This can lead to platelet aggregation, shearing stress from the high blood flow rates in dialysis and the mechanical forces. Membrane compatibility. For example, there's a membrane polysulfone, which has shown to have a higher level of thrombin formation and platelet activation. And then also they found that complement activation can trigger C5a and then express tissue factor on neutrophils, and then that leads to clot formation. And so we know that patients with CKD are increased risk of clots. ESRD itself or dialysis for these end-stage renal disease patients didn't decrease the risk of clots, but what about these patients compared to the general population? So there was this study done, it was a large retrospective cohort study in Canada in 2018 that included 70,000 people with adult incident dialysis, and they were age and sex matched towards the general population. And the goal was to determine, like it says, the risk and complications of VTEs and dialysis patients. And so the primary outcome for the study was a 3-year incidence rate of VTE, and then this was also excluding AV fistula clots and catheter clots. So it was only for systemic coagulation. And as you can see here, for adult patients, there was an incidence rate of 37.1 versus the general population of 8.1 to develop a VTE. And when put into a hazards ratio, and this hazards ratio was actually adjusted for comorbidities. It was adjusted for recent fractures, malignancy. The hazards ratio was still 2.9, so they were 2 times more likely of having a VTE event if you're on dialysis versus the general population. And this is just looking at the data. As you can see here, the 2.9, the adjusted hazards ratio, and then it was actually PE, which had the highest hazard ratio, but DVT was high as well. And another reason that I thought it was important to bring this up is because of mortality in patients who have a VTE while on dialysis. So if you compare, and this again, these patients were matched 1-to-1, and then they had adjusted hazards ratio at 2, and this is with their secondary outcome they were looking for, which was thrombosis, and then also death within 30 days. So if you have a patient with dialysis and a patient that is matched to them, if they both develop a VTE, the patient on dialysis had a 4.6 times more likely to pass away within the next 30 days because of a VTE compared to someone else in the general population. Okay, and then now looking at the other part of this myth, which is, does heparin itself in the dialysis decrease the event of VTEs? Does this cause a systemic anticoagulation? So there was a study done in Stanford in 2013, which was studying the safety of heparin maintenance in dialysis, and this was mostly to look at patients who were at increase of bleeding risk, but they also had a secondary outcome, which was looking at the thrombosis. And so they had 12,000 patients. They were not on warfarin the last year, and they were followed until January 2010. And so the idea is that if you have 2 patients on dialysis and you have one with heparin and one without, right? The patient that has heparin, if the idea is true that heparin decreases the events of VTEs, when comparing no heparin with heparin, it should technically be decreased. But what they found was that the hazards ratio was pretty similar between heparin, between dialysis with heparin and without, meaning that the heparin did not decrease the VTE. So it truly had no effect in protecting you from a VTE. And then looking at this just a little more, so this is, again, the dialyzer, and the only thing that was significant was that the patients who did not have the heparin had more coagulation of their dialysis filter of the circuit, so it had to be replaced more often. But when looking at the average KT/V time, which is actually looking at the adequacy of dialysis, the dialysis was similar for both, meaning they both had the equal amount of toxic metabolites removed, electrolyte imbalances that were resolved, but the heparin being there or not did not change that. But at the same time, with or without heparin, you still had the similar amount of clot formation. And then just out of curiosity, I looked at hemodialysis versus peritoneal dialysis. And this was looking at, for example, if you have 2 patients on dialysis, is it that peritoneal dialysis puts you more at risk and heparin hemodialysis protects you? So looking at this study here, which is actually going back to that previous one from 2018 in Canada, they looked at, here you go, peritoneal dialysis and hemodialysis, and you see that the incidence rate for both is pretty high. It's like 39.8, and then peritoneal dialysis is 28.4. But when you have an incidence rate ratio here and putting heparin at 1 as a standard, peritoneal dialysis was 0.71, meaning that even compared to peritoneal dialysis, hemodialysis does not protect you from VTEs. And this is looking at here a little bit further, it's just the data. And then the last part of this talk is talking about systemic anticoagulation, also looking at if you receive heparin during hemodialysis, is this going to cause sufficient anticoagulation to be able to prevent the formation of PEs or DVTs? And so there was this study done in France in 2023, and it was a cross-sectional study with 35 long-term hemodialysis patients, and the pharmacokinetics of heparin was studied, and it was performed at the beginning of the dialysis session for 6 hours after. So it was a 10-hour total, and it was a 4-hour session. 4 week would be horrible, of dialysis. And then, so looking at the pharmacokinetics, we know with heparin, we monitor the anti-10A level. When it comes to DVT prophylaxis, something we use in the hospital, like 5,000 units of heparin, Q8 hours. It also can change depending on the patient, but usually the goal range of anti-10A is 0.1 to 0.3, but we don't monitor this anymore because we have a lot of data. But in the study that they did here, when it came to anti-10A analysis, they used something similar that we use in hemodialysis center, which is an initial bolus of 25 to 30 units per kg, followed by a continuous infusion rate of 1,500 to 2,000 per hour. And what they saw was that the peak level of anti-10A was 0.55. So it did reach that level slightly above the goal range, but then decreased to less than 0.1 within 90 minutes of this session. So what this tells us is that while heparin is effective during dialysis, its anticoagulant effect diminishes quickly after and doesn't offer a sustained prophylaxis against DVTs. So in conclusion, we learned that CKD is a prothrombotic state that increases the risk of VTEs. It is even higher in patients with dialysis, although we would expect it to be less, and removing some of the factors. The other thing is that ESRD which means patients who are on dialysis, when compared to the general population, have an increased of risk, so it doesn't protect you in that sense either. Heparin in the circuit, when it was studied with or without, the VTE risk was the same. And then also, the heparin itself was even higher risk of other long-term modalities like peritoneal dialysis. And then lastly, systemic heparin levels during dialysis were shown to just be transient during dialysis and decrease within 90 minutes and did not achieve a long-term systemic prophylactic anticoagulation level. And then one of the other reasons I wanted to bring this up too is I remember in practice sometimes thinking about ESRD patients and if they have increased respiratory stress, or we think, well, I have heard in different occasions like, well, less likely to PE because they're on dialysis, but now it's considering that it's not always fluid overload, that they could have PEs as well. So in conclusion, heparin does not decrease your risk for clots. Okay, thank you.
Any questions or comments? Anybody?
That's great. Myth crushed, I think. So in the hospital here, we don't use heparin in dialysis except very, very rarely. So the nurses come much, but at the outpatient unit, they use heparin. Very good.
Any other comments or questions?
What do you think is the cause of, I didn't know that ESRD patients on dialysis had increased risk of VTEs. And it seems like 2 to 3 times higher is kind of high. Why? What do you think is?
Yeah. Well, I saw that even compared to like peritoneal dialysis, it was higher. I guess like one of the differences, the way the blood is going through the circuit, like those types of shearing forces, I don't think the patients are exposed to them as much. I think also, for example, like in peritoneal dialysis, you usually have a catheter versus with patients with fistulas, you're constantly exposing the needle, so you can have, I think you have a greater risk of microemboli and air embolisms causing platelet aggregation. And I think overall, it's a lot of stress on the body too, and I think that also causes procoagulant effects.
I think that's probably all true. And then also that they essentially, the average length is what, 3.5 hours probably outpatient, but it's probably like 4 hours in the chair door to door. So they essentially take a 4-hour plane ride 3 times a week. And that's, I don't think that's nothing, but these are sort of the sickest of the sick patients. So that's good. Yeah, heparin is just for keeping the filter.
Do you think the filter itself activates the platelets?
Less than they did, right? The newer ones. That's what I was taught. Yeah, but probably to a certain extent. And there are filter reactions for patients. Like if you sort of pull dialysis patients, they'll say they're okay, but they may have like a mild headache on dialysis like all the time, and that may be like a little bit of a filter reaction, stuff like that. So yeah, they're better, but they're not 100%. Absolutely.
Any other comments or questions? How many people have, well, we'll vote now, I guess. Well, how many people have actually heard this before? Because I have kind of a list of topics that people are always asking me for topics, but, and I put this on the list like 8 years ago. And after having heard this from a nephrologist, I don't remember which one, who it was. I don't think it was either. It definitely wasn't Dr. Ross, and I don't think it was Dr. Joseph. But that we didn't need to use DVT prophylaxis because, or not to worry about it because they're at decreased risk, for developing clots. And so that's where this topic came from. I don't know if that's still a lot of the studies that Dr. Ochoa presented were actually more recent studies. So I don't know if that was the thinking back then and it's not the thinking anymore. Or what's the general consensus, do you think, in the nephrology world? It was never a thing?
I was never taught that dogma. I was only, I didn't know about the increased risk of VTEs and dialysis patients. But I just was taught that they were just like any other patient, they deserve DVT prophylaxis.
Okay.
That we may give heparin on dialysis, but it's purely for the winter, it's not for AFib, or it doesn't supplement the sub-Q heparin, or once daily Romanox or anything like that. And I think Daryl brings up a good point too. We don't use heparin in the dialysis unit here in the hospital because patients have GI bleeds and all this other stuff just for sort of, we only do like 3-hour sessions. We just sort of need to get them, we're not doing their standard therapy for the most part. And so even more importantly in the hospital, they definitely need DVT prophylaxis because we are giving them any heparin in the dialysis unit, which doesn't even seem to be working anyways.
Yeah, at least for this problem.
Yeah.
Okay, well, I think it's time to vote. Patients on hemodialysis with heparin are not at increased risk for venous thromboembolism. So how many people think that this is true statement? How many think it's plausible? And how many think it's busted? It's pretty unanimous. All right, good job. So, all right, we're busted.
I've waited 3 years for that.